the Department of Neurology here in the city at NYU, and we have now over a decade of experience sending tES home to our patients in clinical trials mainly, but we also have a clinical tES telehealth service that serves the United States. So high volume experience with tES, and so what I really want to pick up on from Dr. Bernoni's talk is just why I really believe that home-based is a way we should be conducting our definitive clinical trials that we really need in the field for tES or related technologies that are handheld and portable. The question is always why go home, when you're trying to determine the clinical effect. And the answer is to do these clinical trials that we need, and I think that we've heard this in themes across the talks today, is that we really need to facilitate clinical trials for larger sample sizes, definitely representative sample patients, and faster completion of our trials just to really move towards clinical use. And so early on, we did a quick snapshot of the importance of going home. Even in Midtown Manhattan, where most of our patients were within 5 miles of clinic, they were still spending a minimum of an hour and commuting at over $15 just for a single visit to our clinic. And again, very close, very urban density. And so you can just imagine something that, any intervention that we're using here is 20, 30 or more sessions, and so it's just not feasible to ask patients to come on site to get these treatments to evaluate as an intervention. And that really brings us to the dosing parameters. In general, I think that this has been rate limiting for the field of clinical use of tES, and that the dosing has not been defined or consistent. We heard Dr. Hanlon's great talk about brain state, which we believe is really important, especially in something mild in technology like tES. And then the unique advantage of home-based use is that we can reach the number or frequency of sessions necessary for adequate evaluation. And after all of our experience, I would really argue that the vast majority of clinical trials, of which there are now thousands in the literature for clinical tES use, have been underpowered in terms of the number of sessions applied for adequate evaluation of whether it works or not. And just, we really believe 20 sessions, so a full month of treatment is something that you would need. And so I first came to tES doing telerehabilitation with cognitive remediation already in people's homes. And so we wanted to add tES to boost that effect. And so I worked mostly with neurologic patients and patients with neurologic disorders. And so we developed a really careful protocol called remotely supervised, or RS-tES, to send this technology home to patients. And so it's built around Soterix's Mini CT, which is operated by a single-use unlock code. And the key, and all the equipment has been really optimized as well as our procedures, with the key feature here being live video visit with every patient at every session. So we clear them before they do any session. And this has resulted in really high volume use. We've completed many clinical trials, thousands and thousands of sessions now. And what we've learned or really demonstrated with these procedures, we can reach almost anybody at home, including people of older age, people who have limited familiarity with technology, people with neurologic disability, motor cognitive impairment, that kind of thing. And so it's really a feasible way to conduct a clinical trial in almost any patient population. This is just a snapshot of the development over time, and we have now in our lab as a single center completed, using this home-based technology, completed 2 class 1 randomized sham-controlled trials, which is what we need to move the field forward. This was in MS, looking at cognitive impairment, and then also in motor rehabilitation. And so that's a single center. And what we're doing now is moving now to a multi-center model. We are the central treating site for NIH's Recover Neuro, which you may be familiar with. Recover is the initiative to target long COVID through the NIH. And treatment trials in Recover Neuro are targeting the cognitive impairment that can occur in long COVID, of which tES is one treatment being evaluated. And so the way this works is that centers across the country are enrolling, and evaluating the outcomes, and we as a single center are treating everybody in a contact with using our RS-tES protocol. So we ship everybody's equipment, and our technicians do people's sessions, every day, no matter what site they were enrolled in. And in this way, really is proof of principle. In 9 months, we've enrolled 328 patients, and we have really high fidelity to treatment orientation. It's a 50-session treatment, so 10 weeks of treatment, and again, it's just been really successful so far. So I believe this model can be used to do the large-scale clinical trials that we need, particularly in addiction, just to pick a treatment to evaluate it and move it towards clinical use. In my travels, because of the home-based technology, I've had the fortune of really being able to collaborate with leaders in the field across all different areas, and this brought me to Dr. Hanlon and her work in addiction. And so together we developed a tDCS intervention or protocol that we're evaluating based and targeting the distress component in the addiction cycle for the first month when people are motivated to reduce either cannabis use or for smoking cessation. And so briefly, we believe this is a generalizable study design. So for a 1-month support of people, again, trying to meaningfully reduce their use of cannabis or for smoking cessation. And it's built all contactless again with national recruitment with 20 sessions. And again, every session is through video visit, and we pair it with mindfulness meditation. And these are active or sham-controlled trials. We've completed ours where we studied cannabis use disorder and women with MS, which is, in essence, it's a very common, cannabis use is very common and can be a problem. And now with Dr. Adicott at Wake Forest, there's an ongoing trial now for smoking cessation in newly diagnosed cancer patients. Just a snapshot to show you again what we can do with this remote trial. So we had very narrow eligibility criteria for the MS part of things because there was a small pilot trial for feasibility and we did more variability. But even with that, we were able to recruit and complete the trial with 52 enrolled in 1 year. And this just shows the snapshot of all the states represented in our trial. And it was a diverse representative group of people living with MS across the United States. And I won't get into it, this isn't the place for me to report the findings, but we were really encouraged by the findings and we're very hopeful that we can continue to use these models to expand to evaluate tDCS as a treatment in addiction models. Part of my talk that I was assigned was the challenges, and I really come from a good news place. We're kind of always continually surprised at how well things are able to be implemented in the home setting. We came with such abundance of caution when we started to design and develop these technologies to send to people at home, and have just been really heartened by the success of being able to deliver treatment to people really in any situation that they may be in need for treatment. I think though with the studying in addiction populations there may be some certain considerations. The screening and verification process, especially when done through telehealth, may be more difficult if it's not a motivated population, so that if people aren't actively seeking to partner with you to reduce their use. We've talked about some safety considerations. Again, I think being live with patients at every session through a video visit really helps, but we need specific protocols. For instance, if somebody's intoxicated at the time that they plan to do the tDCS session, or things like that come up in our considerations. Biospecimen collection is Dr. Hanlon's taught me some good techniques. There's a lot of things you can do in a video visit with verification with urine strip. Or smokalizer or breathalyzers, those kind of things. We can also use local labs if it's a multi-center trial, so it's doable, but additional things to consider. And then not specific to addiction population, but equipment and logistics, I just have to always say, because people always consult with us about how to do these home-based trials, be sure to budget for shipping and receiving. We have a whole shipping and receiving department. I feel like I should publish about shipping and receiving. So it's a thing, and especially because of the expensive equipment, we loan the equipment out, and so we hope to get it back. We've been very happy. Over 99% of all of our equipment in 10 years has been returned, which again I would like to publish. It's pretty remarkable. But that's part of things too, is just to make sure that the equipment and its integrity, that you can get it there. And there's special different precautions as well with shipping and receiving. But again, want to just voice how feasible I believe home-based use is. This is my team. I just want to thank them who do the heavy lifting every day. This team alone, right now in the Recover Trial, we have 126 patients doing daily sessions in our little lab. So we can really, it's a very scalable way to reach people in these trials and do them quickly.